So I'm Suzette Fox and my colleague Helen Redfern. So we have these next few minutes just to explain very briefly what our project was about in the funding that we received from QRTN. So I'll skip through these first couple of slides to get to the meat of what we actually achieved. Our project objectives overall was to establish and trial a clinical rotation model. We wanted it for final year social work students in the aged care sector at the Royal Brisbane Women's Hospital. We had some specific goals around that about developing skills and changing students' attitudes. Our key performance indicators are set out there and I'll let you read that, but basically we recruited 6 students from 3 local Queensland universities. We were using a rotational model that is established in the US, and they rotated across, we utilised 4 clinical settings at the Royal Brisbane Hospital, Women's Hospital, that has a large population of older people. And amongst that, we recruited or had the involvement of 12 social workers, 12 staff within that. The program itself was supplemented by workshops and peer supervision groups. This slide actually shows probably the model as a whole, or the key concepts of the model. What I'd like to point out with this is that the overarching goal was to provide a really a good quality clinical placement for the students in aged care and working with the older population. Initially, our innovation was in the collaboration with the 3 universities, and we put a lot of time and effort into establishing that. But as the project proceeded, then what was really encouraging and exciting was the collaboration that happened not just vertically but horizontally. And I was really thrilled with Dom's presentation and talking about that, because I thought, to me, that's really what made it work, was this vertical and horizontal collaboration. So across those 3 clinical areas, the chronic and rehabilitation, medical and extended care, and cancer care. This slide shows I guess another way of understanding the rotations. In social work, students have a placement. They have 2 placements, one in 3rd year and one in 4th year or final year. And the placements go for about 18 weeks approximately, and the usual traditional placement model has been a one-on-one apprenticeship model. Now that may be shared between 2 clinicians, but one person or 2 has the responsibility for training the student, for teaching the student over the duration of that. And so what we were seeking to do was to shift that from that apprenticeship model to embedding it more in a team approach, and to instil in them a greater interest and capacity, particularly to work in the aged care sector. In the first rotation, a lot of emphasis was placed in that. That went for longer than the other rotations. It was 6 weeks, and in that time, a number of things had to be developed, as you can see there, but basically the aim was that first rotation provided a foundation for the students. They were assigned a field educator, so we took the strengths of that one-on-one relationship, and in that time, in that first clinical placement, that became the students' home base, and that field educator that they had in those first 6 weeks, that relationship was sustained as they rotated through the other clinical areas, which meant essentially that they returned, when they were in the other rotations, they returned each fortnight to their original clinical educator for supervision. And as I said, that was supplemented by task supervision, which was carried out, peer group or group supervision carried out by Helen and myself. In the 2nd and 3rd rotations, their task learning was supervised by task supervisors, and as I said, it was supplemented by the workshops. At the beginning of each rotation, the students were withdrawn from the clinical area for intensives and the workshops, which Helen will talk about. But we also wanted to know, we didn't just want to trial a rotational placement as something new and different. we wanted to evaluate that, and we based that on what the literature showed us, which was that there's a deficit, a real struggle within the healthcare sector in recruiting and retaining clinicians to work with older people. And that was predominantly, a number of factors impact that, but that was predominantly around negative attitudes and ageist attitudes towards what it actually meant to work in that area and work with older people. So even though we were recruiting students who had a positive attitude, we wanted to see an improvement in that. And so we did a pre and post test, with the intervention being the placement. I'm just have completed the results of that, and even though we only had a small number of students, so not any statistical significance with that, there was quite a remarkable increase in the positive attitudes that they already had. We'd had a reflective writing piece at the beginning, and I've conducted interviews in the last week of the students' placements, just in the process of analysing that and getting feedback from field educators. What I'm starting to hear is from the interviews is that the students were overwhelmingly thrilled with their learning capacity. They were able to compare their placement with other students that had the traditional placement, and while they saw that those students were gaining in confidence initially, what they valued most was, and a number of them said to me, I can walk into any department of this hospital now and be ready to start work. And so that work readiness was a really powerful outcome from that. And Helen's going to talk to the curriculum.
Yes, as part of this also, it wasn't just the clinical rotational model, we also had a look at, we found an extensive body of work in the US where they'd not only developed clinical rotational models but an adjunct curriculum beside it. Equally, in working with our academic partners, which was QUT, University of Queensland, and my university, the Australian Catholic University, there was a considerable variance about how much was taught on ageing and healthcare. Some universities had units specifically dedicated to that. Equally, we didn't want to just have students that came from those units as well, because we wanted to be able to attract any students coming through for a health placement. So we were fully aware that we were getting students through that needed some sort of curriculum to be taught as well. So what we looked at was obviously the US model, and they had actually articulated a number of a particular framework, which you'll see on the slide up here, looking at both the social, biological and psychological. Model incorporated the specifically designed curriculum that transferred theory and knowledge into the service delivery. It aimed to provide students with the ability to work effectively in a professional social work role with older people, to develop core skills for competent social work practice in the health context, and to teach students how to manage the complexity of elderly patients in healthcare settings. The teaching component required collaboration with academics, so we had an academic advisory group. We also had a clinical advisory group that worked with us to develop this curriculum. It also necessitated, we continued to engage these stakeholders in the program, and as we gathered feedback from the students. We ran a number of workshops. We ran a couple of workshops at the beginning of placement, and in those workshops we looked at the context ageing. We also were very keen to be able to influence the attitudes of students, so we looked at the whole concept around myths around ageing and got them to challenge that and to explore their own values and beliefs around that. So that was in our first workshop, to actually prepare them. The workshops that then proceeded after that focused on assessment and intervention methods, also focused on ethics, also focused on critical thinking and critical reflection. There are other specific issues that we looked at too that were specific to ageing, and that was we taught around the 3 Ds, depression, dementia and delirium. We also looked at issues and got clinicians in to actually do some of these presentations in the workshops around capacity and end-of-life issues as well, things that were specific to working with older people. The workshops were in a number of different formats. The workshops were both interactive, as well as we used a whole number of different teaching mediums, including lectures, workbooks, etc. Equally, the students had often pre-reading material to do before the session, but we were acutely aware that obviously these students were often had a lot of other university requirements for them to meet, so we were very conscious not to give them too much extra to read or to take on board. So most of the work that we did was pretty much in that workshop environment, getting them to actually work through some materials, and we would follow up with that in the group supervision processes, both Suzette and I. The other thing that we looked at was that obviously our program, our curriculum aligned with our practice standards for the ASW, the Australian Association of Social Workers. We aligned it very clearly with that, but our practice standards are very generic. They're not specific to working with older people. Again, we looked at our US colleagues and found that they had developed a number of core geriatric competencies, and we actually aligned the program and developed the program around these competencies. Our US colleagues had also developed a competency scale that the students could actually self-evaluate on, and we asked the students to do that prior to placement, pre-placement, and then they've completed that competency outline at the end of placement in consultation with their field educators and task supervisors. As you can see, there's a range of different areas we covered there. That was incorporated into the content of the workshops. The materials we have developed with the project is that we've developed a placement tracking document suitable for the use across several tertiary providers. The aged care curriculum. We've also developed a number of teaching program materials and resources, such as lecture materials, other sorts of models to be used in the practice context, and again a number of group supervision materials and resources that we developed as part of the project. Where to from here?
So just in summarising the lessons learnt and the sustainability of it, Helen has with her an outline of some of the materials, if anyone's interested in looking at some more details with that. In your booklets also, you'll have a handout that actually shows how we've met the criteria for deliverables for the program, and it also talks about the CAOP, not the CAOP scale, the HIPAA model that we've used, and we've balanced that on. I think in terms of lessons learned, it's really a rich field in that. For me, I guess one of the key things was the need for flexibility of the model in the changeable clinical environment. It's interesting to create a cultural shift and significant change, moving from a traditional way something's been done in the midst of change. Change happens within change, and while on one hand it seemed kind of an overwhelming task, on the other it was the perfect opportunity to try and do something different. But there was a need to be responsive to the organisational change and to what the students' needs were within that, and which the model was able to do. Halfway through we shifted some of their rotations to accommodate what was actually happening for the students. So that need for flexibility within that was probably a key lesson that we learnt and that we've embraced.
We also had a number of challenges in the project. Halfway through the project, my position was abolished at the hospital because I had a part-time position with the Royal Brisbane and a part-time position with the university. Luckily, I was a tertiary partner, so I was able to flip over and continue the work in an honorary capacity. But that was a major challenge. Equally, there was a major challenge in our clinical environment with a number of staff lost in the department. So maintaining that stability within this model was really quite a challenge, but also showed us the durability and the sustainability of a particular model. One of the innovations probably we wanted to be able to identify to you is that when we looked at the US model, they run clinical rotations, but they are university-driven. Our innovation probably lay in that ours was industry-driven, bringing 3 universities on board. That hadn't been done in America. We actually compared our model against something like 22 or 25 different clinical rotational models from the US. So we think that what we've done is a little bit innovative from what the our US colleagues have done. Did you want to make up the comments about this?
And I guess probably the final thing in terms of sustainability is that we intend to get some publication. We've started conversations around publishing some of the findings that we've had and some of the experiences that have come out of that. But also we've had early discussions with a number of people around duplicating it or replicating it, with taking on board the lessons and the changes in order to create a real shift in the way, in the sustainability of social work, field education, and the links between industry and university, government and non-government. And it certainly has early discussions, but quite a very hopeful that more will be able to be built on that.
Suitability for other allied health professions. I think the actual model could be very suitable to other allied health professions. Obviously, I think based on our previous speakers' comments about what is specific to disciplines and what can be interdisciplinary, we have had some discussions around that. The curriculum we developed would be the equivalent of a university unit. It was in total with the group supervision and the workshops a total of 37.5 hours, which is almost the equivalent of one university unit. So easily that could be adapted through university as well, we think. So
that's us. Thank you.